Buenos dias. I too would like to thank the conference organizers for inviting me and being such gracious hosts and putting together such a wonderful program, because I too have had an opportunity to learn from the presenters that we've heard from thus far. So I'm going to take you back a little bit from the broader context that we've heard about to talk a little bit more about individual and family behavior. And then hopefully at the end we can put it all back together again. So briefly, I'm going to talk a little bit about prevalence, why we care, which you all know about already. To talk about lifestyle interventions, in particular with children and adolescents, and then talk about some of the steps that we've taken to translate these interventions into the community. Okay, so everyone's aware of these numbers. We talked about it yesterday with regard to adults, but here you have it with children. And there is a precipitous rise in obesity rates, and you see it from the decades from the 70s until 2009, 2010, and you see it across all age groups. These are our racial ethnic groups mixed together. When you break it down, you see that there are a number of disparities affecting Latino and African American children in the States. And this I thought was interesting. If you looked at the left panel, this is from a large nationally representative data set in the United States, looking at waves of data, so over roughly 13 years. And you see that in our adolescents, actually, the bar on the top, or the line on the top, represents Mexican Americans and Puerto Ricans, and you see that we start out at the same rates of obesity as our non-Latino whites, but over the course of adolescence, there's something happening where those teens are incrementally gaining more weight, which just reminds us of the importance of, if we haven't been able to help up until this point, that adolescence continues to be an opportunity for intervention. Why do we care? The focus of this meeting is type 2 diabetes. Really, up until the 1990s, people didn't talk about type 2 diabetes in children and adolescents. But here you have our prevalence rate is 20.24 in 1,000. But you'll see that's disproportionately represented among different groups. So of the new cases of diabetes diagnosed annually, you'll see that relatively few cases in non-Hispanic whites, much greater in Hispanics, Pacific Islanders, and American Indian youth. Other comorbidities that are associated with obesity, even in children and adolescents, are cardiovascular disease, the beginning signs of cardiovascular disease, pulmonary diseases, and non-alcoholic fatty liver disease. You've seen many models that are comparable to this in terms of making the point that obesity is a complex issue, it's a multisystemic issue, and we need to pay attention to all of these circles in order to fully understand and be able to intervene. I'm going to focus today more on the inner two circles. And there's my attempt at Spanish. One of my colleagues translated that for me, so hopefully it's right. What I wanted to say is congratulations on getting the soda tax passed, which is a great example of a policy change that can then have a synergy with an individual or a family level change to support individual decision making. Okay, so I want to talk a little bit about what's been done in the States with regard to intervening directly with type 2 diabetes, particularly because this was a large multi-site trial that recently wrapped up, and the data became available within the last year or two, and I think it's relevant in thinking about type 2 diabetes. So this was a sample of almost 700 youth, all with relatively new onset type 2 diabetes, predominantly female, and they were randomized to receive either metformin and rosiglitazone, which I cannot say. I'm going to call it Rosie in the next slide. So I'm just, or metformin and lifestyle. And this was across 15 different clinical sites. And here you have their data with regard to BMI and percent fat mass. And what you can see in the green is the metformin and lifestyle. And you see that actually they showed the least weight gain, that's the language we're using here, with regard to BMI and also fat mass. The group that did the best was the one that had the double medication. In contrast, those findings didn't translate, so the BMI findings did not translate to glycemic control findings. And so this is a slide showing you the survival curve for freedom from glycemic failure. So basically, their primary outcome was when the kids became unstable with regard to their hemoglobin A1C. And the group that did best here is actually the group that got the double medication, which was exactly the opposite of what we showed in terms of the BMI. So the take-home that I want to present or that I want to convey with this is that really once kids already have type 2 diabetes, it is increasingly difficult to intervene. And our standard first-line intervention, which would be metformin, actually only was effective in 50% of the kids. So in 50% of the kids, that failed rather quickly. This is, in contrast, I know it's difficult to read, but shows you data from a lifestyle intervention with adolescents. And if I can do the pointer without going crazy, which, forget it. In any case, if you look at the circled column, technology is not my shtick, you will find rather quickly, that here instead, in contrast to the previous study, with changes in BMI associated with a lifestyle intervention with pre-diabetic kids, we're actually showing some changes in some of those key metabolic parameters. And here, just to make that point again, this shows you insulin sensitivity, and you see the lifestyle intervention in blue, the control group in white. So improvements in insulin sensitivity in these pre-diabetic teenagers with a lifestyle intervention. So that brings me to what is a lifestyle intervention, and really what I'm going to spend most of my time talking with you about this morning. So lifestyle intervention, as we deliver it with children and teens, is sort of the first line of intervention with kids who are already struggling with overweight and obesity. And it consists of some fairly basic components. So first, there's a targeted reduction in energy intake, as you might expect, increase in energy expenditure. And this is what's a little bit different when you're working with children. It is equally important to target parents or caregivers as well as children. And this is particularly the case when we're talking about school-age children, so kids between the ages of 8 and 12, or 12 and under. And what we're trying to target is both information, so conveying information, but also working on strategies that support changes in behavior. And the kinds of things that we include to help with that are things like self-monitoring, so basically keeping track of diet and physical activity, reinforcing, so being positive in whatever way makes sense to the particular child and family for achieving those goals. And then, in light of what some of the conversations we've had over the last day and a half, stimulus control, meaning to what extent is the environment, or how can you manipulate the environment to increase the likelihood of success for a particular child or a particular family. This is a commonly used dietary approach with kids. It's called the traffic light diet. And it's probably obvious. So basically, this approach categorizes foods in terms of red, yellow, or green. So red, as you might think, unless you live where I live, in which case red usually means speed up and run through the traffic light. But for most people, red means stop and think. Okay, I see the delay in translation, that's fine. Okay, so red meaning, we don't have I think we talked a little bit yesterday, fat, sugar, what's important. Red foods in this classification are actually those that are high in both fat and sugar. less nutrient dense. I think we would all agree on what fits there, versus yellow foods, which is caution. So these are things that we eat, but think a little bit about how much we eat, versus green foods, which I think everyone will agree on this category, foods that are naturally nutrient rich and low in caloric energy density. Are fruits and vegetables. That's the one time I'll say fruits and vegetables. So this is the diet that's most commonly used and for which there is most evidence in interventions with children. And I show you a slide just as an overview of some of the studies that have been done with children and their efficacy in lifestyle interventions. So this shows you in the left panel children who did not receive a lifestyle intervention. In the middle panel, those for whom the intervention was directed only toward the child. And then closest to me on the right are those families for whom the intervention was delivered to both the child and the parent. And you'll see that over 5-year follow-up and as long as 10-year follow-up, there are significant changes in percent overweight that are maintained. These data are from Len Epstein, who's done probably the most significant body of work in this area. But there are more recent studies that show similar kinds of changes, maybe not out to 10 years, but showing that if you target a parent in particular of a school-age child, you can get some impact in terms of that child's behavior and improvements with regard to weight status. Now we come to adolescence, which is where I spend most of my time. And you might ask why, if you hear some of the things. But with adolescence, we know much less in terms of what's effective. And I think there are a lot of reasons for that. At least in the States, and you all can clarify for me or help me understand to the extent to which these same things are true in Mexico. But with our teens, there's more time spent out of the home. The role of the parent is not so clear. 1 minute I have a teenage girl and a boy. 1 minute I'm best friend. The next minute I'm the worst enemy. And it's very hard to predict which one I'm going to be at any given moment. So it's hard as a parent to have a clear role, especially when it comes to weight control. And we have normative developmental challenges in adolescence. So at least culturally appropriate in the States, teens are striving to be more independent, which means they don't really want to rely so much on their parents. There's a focus on appearance, there's a focus on their peers, and sometimes there can be lack of cooperation. So what I want to talk about is some of the studies that we've conducted to work with adolescents and their families and the extent to which they have or have not been effective in achieving those goals. Okay, so the first thing I want to talk to you about is a couple of studies we did that involved trying to mobilize peers, so friends, or creating a group of peers or group supports for teens. And the reason I came to this is I thought, well, who do teens listen to? They don't listen to their parents that well. Who has a lot of influence on them? And I decided other teens have a lot of influence on teens. And so based on that approach, thought, well, maybe we can use other teens to sort of build support, but also help mobilize each other in terms of the goals that are needed for better weight control. And so we developed this, I just made up the name, which I called Peer Enhanced Adventure Therapy. So I don't know if people know what Outward Bound is here? Maybe not. But Outward Bound is this idea that you have experiences that help to build confidence and help to build your social skills by creating different challenges. So for example, kids are asked to accomplish something that's kind of challenging and it takes some work and they have to work together as a group to achieve that. And I'll give you an example. This is, we do these ropes courses where in this, that's snow. They have to go out even if it's cold. So basically they work together to be confident enough that the person on the ground is going to hold them, the person on the ground is holding the rope, so they're going to be fine. So this is the kind of team building, confidence building experience that we used in our outward bound model. This wasn't what we did every week, but this was the kind of thing that we did. So our procedure, which is similar across our studies, is to we do include teens and their parents. And we ask them to spend a couple of weeks before they start actually keeping track of what they're eating, and we don't care how they keep it. There are a lot of apps now that you can use on your phone that allow that, and that's fine. And then once they did that, we randomly assign them to get either our typical behavioral treatment for weight control with that outward bound kind of model, or with just coming together and exercising as a group. Okay? And we included kids, and this is true in all of our studies. Well, the second part's not true. 13 to 16, BMI greater than the 95th percentile. And they had to have one caregiver willing to participate in the intervention. And this is what we did. So we had 16 weekly group sessions, and in our studies we have separate meetings for parents and teens. We did a balanced deficit diet. We did it based on the exchange system, so the diabetes exchange system. And the reason I did that is I wanted to have some control over the kinds of calories that kids were getting. So if you just give a caloric prescription, as we heard a lot about yesterday, you don't have any control over what in particular people are eating. So by doing it this way, it was, you have 5 fruits, 4 vegetables, 3 starches. Those are made up numbers, but you get the idea. And then what was different is in our exercise group, they came also and exercised together as a group, as you might expect from the title. And in our peer-enhanced group, we did these weekly trainings that were really trying to build up their skills and their communication and their self-esteem, because we know actually that self-esteem relates fairly highly to how well kids do in weight control programs. Okay. So we actually conducted 2 different trials to look at a similar kind of approach, and this just shows you across the 2 studies the sample that we had. So our mean age is about 14 and a half. Our baseline BMI, we have primarily girls, and then our ethnic mix, and then our retention. And so the second study you'll see was longer, so we went out to 24 months, so 2-year follow-up data with that study. And just to briefly show you the findings, so from the first study, you see that we got significant decreases in body mass index, and those were sustained at least short term, and there's no difference there between the groups. So our big fancy outward bound, let's have them climb ropes, and didn't do any better than having them come together and exercise as a group. And when we did a follow-up, longer term, out to 2 years, of the same kind of intervention, we found the exact same results. So basically, we can fairly reliably, at least among these teens, show a 10% decrease in percent overweight that's maintained at 2 years. So in the context of running those interventions, I ran all the parent groups, and I was struck by how critical the parents were often of their teens' efforts, and how they tended to be sort of hovering over them. Did you write that down? Are you opening the refrigerator? Shut that door. So the parents were really very involved, and not always in a positive way. So I decided that while we know a lot about how to deal with parents and weight control interventions for younger kids, we didn't know that much about what to do in the context of adolescents. And there are some natural challenges, as I alluded to before, with what the role of the parent is with teens. So I think, teens need parents, but they don't want to need parents, and, so it's hard to sort of figure out where they should be in the context of a weight control intervention. So we did a small study just to look at that, to specifically look at what about if we give parents different roles and look to see what difference that makes in kids' weight control behaviors. So this was a smaller study, but we randomized pairs of teens and caregivers to either an enhanced parent involvement condition or a minimal parent involvement condition. And this was a short-term study, so we really just looked at baseline and then follow-up. And we measured some different domains. And here, just to give you an idea of what the enhanced intervention looked like, parents came to weekly groups. We asked parents to also do all the things that the teens were doing. And my reasoning for that is if the parents were having to do it as well, they might be less likely to be criticizing their teens, frankly. The other thing that we did is try to work on the communication between the parents and the teens as it related to weight. So if you want your teen to do something, is it helpful to keep nagging them and asking them 10 times? No. Let's learn other more effective ways to communicate about these things. So that was our very, involved parent intervention. In contrast, in our what we called our minimal parent intervention, we took a very different approach, which was forget the parents. They don't really matter so much. What matters is what food they bring in the house and making sure they provide you opportunities to participate in physical activity. But other than that, we're going to sort of leave them out of it a little bit. So that's wrong. They intended 3. So instead of 16 sessions, they only came to 3 sessions and really focused on, change the food environment so you can better support your teen. And what we got was exactly opposite than what I was expecting. So this is, I just did this discrete, showed at least 1 BMI unit decrease or better over time. And on the left, you have our minimal condition. So half of the teens were able to accomplish that in our minimal condition. In our enhanced condition, we did not do nearly as well. So basically, we did much better when we took the parents out of it and gave them a much more focused and minimal role than we had them so involved. And when we asked the teens, what happened? What was it like having your parents involved and all of this? After the fact, what they said is, you have to, I don't know how to translate this, but basically you got to walk the walk and talk the talk. So what happens is parents would be not really doing what we were asking them to do. So we found we got a lot of stories about secret stashes of food in the garage, behind the draperies, in the window. And so basically, if you're asking parents to be models, particularly for teens who are going to be just waiting for their parents to screw up, parents better be good models. And if they're not, then I think, it's better to have them less involved. And then, in fact, when we we had a measure of responsibility for weight-related behaviors. So, who decides what food comes into the house, who decides what you eat for dinner, when you exercise, all of that. We did show an increase, actually, in our minimal condition, which is in the red, in the amount of responsibility that teens were taking for those kinds of behaviors. And the increase in responsibility was actually related to decrease in weight. So more responsibility, better outcomes. So that was a lesson learned and kind of an interesting study to run. So hopefully I've convinced you to some extent that there are comprehensive interventions for moderately obese teens that actually are reasonably effective. We're not dramatically changing kids, but we are absolutely changing their trajectories and showing some level of meaningful decrease. So our goal is to, that's great, you do your randomized trial and who benefits from that. So the goal is to figure out then how we can take some of the principles from these models or some of these take-home messages and translate these into broader settings and community-based interventions. So this is a nice framework that's used very commonly to think about scaling interventions, and it's the RE-AIM framework. So basically asks us to take a step back and think about what are we doing with our interventions. So in the area of reach, right? So to what extent are we actually reaching the kids who we want to be reaching, who need to be reached? Are we being effective versus, efficacy is our clinical trial, effective is what are we doing that's reaching more people? So and along with that, and we heard a little bit about this yesterday in the area of adults, but there is actually in the States a USPSTF recommendation for 6 to 17-year-olds requiring that they be screened and actually referred to comprehensive programs, meaning the kind of multidisciplinary or attention to diet, exercise, and behavioral strategies that I've been talking about. So we have these clinical trials that only reach some small percentage of the population. We have a demand to be offering these interventions and a call to action to be offering these interventions more broadly. So what do we do? And so one of the things that I was involved with was actually an effort to take the things we know and to deliver these in a more scalable intervention delivered through the YMCA. So in the US, YMCAs are quite popular, and I think when I looked at the map, there's one in Mexico, but really well-regarded community-based settings where lots of kids and adults go to participate in physical activity and other kinds of, actually now they're doing more health programming as well. So we collaborated with an insurance company, the YMCA in Greater Providence, which is where I'm from, and to sort of look at, can we deliver an intervention that's based on some of the principles that we talked about, but in a community setting and actually delivered by community facilitators. So not these highly trained, folks who we typically work with, but who's working already at the Y and who's delivering, say, some, the cycling program or whatever it is. Can we train that person to deliver a behavioral weight control intervention? And if we do it, is it going to be effective? So we recruited, I'll come to it in a minute, but 150 plus kids. Sorry? And so just looking at, to talk quickly about what's the traditional kind of thing that we do, and then what did we change in order to make it more community-based. So I'll just highlight the things that we changed, which typically we would see kids and parents in separate groups. In a community setting, that's not possible. So we were told one room, you get one room. So you got to fit everyone in one room. Okay, so one room for everybody. And as I said before, these were delivered by YMCA staff, not our staff. We trained them, and then less intensive than what we typically do. So this was 12 face-to-face meetings, and then we asked parents to conduct home sessions for 12 weeks. We did train the facilitators, so we involved them in 5.5 days of in-person training, and then additional training right before and during the course of the intervention. And then we would have weekly phone meetings with them so that they could discuss, issues. So we recruited 155 youth, and they span the age continuum from 6 to 17. Unlike our typical studies, so we only excluded roughly 25% of the kids who called. So almost everyone ended up enrolled, about half girls. And what do I want to tell you about that? Actually, the attendance was quite good. So 88% completed their 12-week assessment, and almost 85% completed at 24 weeks. And here you have our outcomes, and I deliberately, because of my interest and because it was interesting, broke out these findings by whether they're teens or kids. So the kids are in the light green. And over time, you see baseline 12 weeks and 24 weeks. Those kids showed a little bit more than a 4% decrease in percent overweight. So this is in the YMCA program delivered by Y facilitators. It's about half of what you would get in a clinical setting, but not bad, because if we looked at the cost, it was much more cost savings. In contrast, we really didn't move the dial very much with the teens. They only showed a 1% decrease. So what we learned in doing this, and I didn't present you this data, but actually the facilitators were incredibly accomplished in delivering this intervention with what we would call fidelity. So we would either videotape or go and check to see, are they saying what they're supposed to be saying? Are they covering the content? And it was something like 93% of the time, they were doing exactly what they were supposed to be doing. I think we also realized that, boy, if you were going to do this in any kind of broader way, you probably couldn't spend 5.5 days training people, along with that more intensive follow-up. So really sort of thinking about, what do we need to do if we were actually going to take this and say the YMCA at 500 sites across the country is going to offer this intervention? What are the steps that we need to take to get there? What are the gaps that we need to close? And I think the other gap that we need to close is, how do we make this kind of an intervention more effective for teens? And I actually have a study right now where we're doing that, where we're testing an enhanced version for teens to try to get better outcomes for them. Just briefly, because we're talking about dissemination and because we're talking about type 2 diabetes, I wanted to just talk about a couple of just exercise interventions, because there are some decent data to suggest that physical activity, and we heard this morning so eloquently about physical activity, can actually move the dial with some of these other parameters, even if weight doesn't change. And so just a couple of quick studies. This one was looking at aerobic training versus resistance training versus a combination of those things among kids who are already overweight, obese. And in this particular study, the best outcomes were for the kids who got both, so the combination of aerobic activity and resistance training. This is a similar study, again, aerobic exercise, resistance training, or a control condition. And you'll see in the graph to the right that the reductions in fat were observed in both conditions. Sorry, that graph shows you insulin sensitivity. So for insulin sensitivity, the resistance training actually was superior to the aerobic exercise. And that's consistent with some work that Michael Gorin at University of South California has been doing that shows similar kinds of findings, and particularly among Latino youth. So I think the exercise interventions are interesting because they potentially offer a different pathway for scaling an intervention that don't require as much in the way of, or require a different skill level in the facilitators. So in summary, I think, obviously we're better served by focusing on prevention of type 2 diabetes and prevention of weight gain. However, for those youth who are already overweight and obese, we have to do something. And I think there's some promise in lifestyle interventions, certainly for school-aged children, and hopefully we're starting to show that with adolescents as well. Our current focus is on translating those interventions into community settings where they can be available to more kids. And I think it's crucial, and our previous presenters have done a wonderful and eloquent job of talking about how sort of thinking about this in the context of broader contexts and synergies within frameworks, so individuals affecting families, and needing to work within a broader context as well to be most effective. Gracias. Thank you.